Hey guys, my name's Olivia, and my drug category project is on ST segment elevation myocardial infarction. I used some of the guidelines from the American Heart Association, the American College of Cardiology, and a few others that were reputable sources for first-line drug, second-line drug, and treatment for this condition. A STEMI happens when an artery supplying blood to the heart suddenly becomes partially or completely blocked by a blood clot. This can be recognized by a 12-lead ECG. There are certain waveforms that will show what kind of heart attack this patient could be experiencing. And the goal for the provider is a quick reperfusion therapy to restore blood flow to the myocardium. This will be the expectations of an office setting or primary care. Patients that present to our office may come in with any of the symptoms on this probability of ischemia chart. There will be some patients that have no symptoms at all. So the best practice is to run a quick 12-lead ECG within 10 to 15 minutes. Once you get that confirmed STEMI, you'll want to simultaneously be running cardiac biomarkers, consulting the cardiologist, and working towards getting an EMS transport to the nearest emergency room. There's going to be different pathways for the provider to take. It will all depend on the time delay between the first medical contact to us, the primary care provider, and performance of PCI, which is primary percutaneous coronary intervention, versus having to do fibromolytic therapy. A lot of this will depend on any kind of presentation of cardiogenic shock, any kind of contraindications they may have to either of those treatment options, time from symptom onset to presentation, and those kind of things. First-line drugs will be supplemental O2, non-enteric coated aspirin, IV morphine, beta blockers, and nitroglycerin. Aspirin is suppresses platelet aggregation. You'll want to make sure this patient chews up 325 milligrams of aspirin for fastest absorption. They will then be later placed on a daily aspirin to reduce risk for reinfarction, stroke, and death. NSAIDs are to be totally discontinued. Morphine assists with pain relief and causes vasodilation, improving hemodynamics. It can also reduce preload and afterload. Beta blockers reduce cardiac pain, infarct size, and improve short-term mortality. These should also be started within 24 hours of the MI, and make sure you assess your patient for shock, heart failure, bradycardia prior to initiating this therapy. Nitroglycerin is 0.4 milligrams sublingual, given every 5 minutes for up to 3 doses. It tries to reduce cardiac preload associated with oxygen demand, so it increases blood flow to the ischemic region of the heart, assists with hypertension, and limits the infarct size. Make sure you warn your patient they could get a headache, and patients who have taken sildenafil, evenafil, or vardenafil should not take nitroglycerin. There's other drugs that this patient will be given as well, such as ACE inhibitors or ARBs, statin drugs, anticoagulant versus antiplatelet P2Y12 receptor blockers, such as Plavix, Effient, or Brilinta. Most of these patients with an acute STEMI will be started on dual antiplatelet therapy with aspirin for at least a year. There's going to be a loading dose. For example, Brilinta has a 180 milligram loading dose, and then you'll be placed on a daily dose for that year. One medication, clopidogrel, which is Plavix. If you're 75 years or older, they will have a different loading dose for you, which is 75 milligrams versus the higher normal loading dose of 300 milligrams. Prevention of STEMI will work with our patient to increase their exercise patterns, change some diet that they have, weight loss, smoking cessation with goals of getting their blood pressure down, diabetics to have a hemoglobin A1C of 7% or lower and a BMI of 18.5 to 24.9 based on their height and weight. These patients are going to be on beta blockers, ACE inhibitors, or an ARB, antiplatelet drug or anticoagulant, and statin for the rest of their life. Some pharmacokinetics and pharmacodynamics of these drugs. For example, aspirin inhibits platelet aggregation. Plavix irreversibly binds to P2Y12 adenosine diphosphate receptors, including platelet activation and aggregation. Rosuvastatin inhibits HMG-CoA reductase and inhibits cholesterol synthesis. All of these drugs work together to prevent future infarcts. Some effects on the body system, particularly antiplatelet and anticoagulants, have a huge increased risk for bleeding. So you'll need to involve your patient with the risk versus benefit in that decision-making process. Same with fibromyalitics. They're contraindicated in patients with systolic blood pressure that's uncontrolled, previous stroke or TIA, current anticoag use, or a prior intracranial hemorrhage. Statin drugs and ACE inhibitors and ARBs are contraindicated in pregnancy. ACE inhibitors are contraindicated in renal dysfunction patients. They'll need to go through a potassium and creatinine clearance prior to a long-term prescription. As well as ACE inhibitors, they have a high side effect of dry, hacky cough and angioedema. Efficacy and cost, I found a lot of up-to-date prices on Hippocrates. Aspirin is definitely affordable, but some of these medications that are needed can be big competitor drug companies. You'll see TV commercials fighting for which is the better drug. So make sure you just can get on GoodRx and look for the best kind of price for these medications. The special considerations in some populations, particularly COVID-19, especially in March of 2019 to March of 2020, there was a significant PCI door to balloon time that was increased because providers were having difficulty deciding if it was related to COVID or more related to the heart attack. There was a lot of talk about exposing healthcare workers to COVID by putting these patients in the hospital for PCI, and a lot of that treatment was delayed. So those are a special population. Substance use, it's hard to sometimes determine. The cocaine and methamphetamine produces a hyperaldosteronic state by blocking neuronal reuptake of norepi and dopamine. So it can raise your heart rate and blood pressure and simultaneously affect coronary vasoconstriction and lead to an MI. It's really a big cost difference from the 1990s to 2018, 103 billion to 226 billion spent on estimated costs of cardiovascular disease, as well as it still remains the leading cause in men and women for death in the United States and accounts for about 4.7% of all ER visits for STEMI. And these are my references.